Hello there, it's Dr. Verlage again, moving on through our topics with our weekly lecture or monthly lecture. So today's topic is titled Recognizing the Red Flags, Early Signs of Perinatal Mental Health Disorders. Yeah, it might be a little bit dry today. We're gonna talk about criteria for depression, generalized anxiety disorder, and then we'll talk a little bit about postpartum psychosis. I'll tell you that as I've moved through medical school and residency and now working directly with patients as an attending, I've realized how arbitrary our different diagnostic criteria are. So I like to think of it more like a picture, what you're hearing, how it's affecting their life, kind of the flavor of what they're describing in terms of their symptoms, versus getting too hung up on technically meeting diagnosis for things. We draw the line at 2 weeks for a depressive episode for us to call it that, but I would be very unlikely to not treat somebody who's had 13 days of symptoms, So, yeah, all of these are to help us kind of think about how long things last generally, the kinds of symptoms somebody can have, maybe some symptoms of different diagnoses that you might not think of. That's good for us to talk about. So I kind of give that asterisk before we delve into some of the more specifics. But let's go into it. So perinatal depression. Or a perinatal depressive episode. So we describe this as happening during pregnancy or 1 year following delivery. I think technically in the DSM they only include a month after delivery, which obviously would exclude a huge portion of the patient base that does experience symptoms that should be included. But to meet criteria for a depressive episode, you have to have, I don't know if you guys have heard of SIGE-CAPS. It's an acronym medical students will memorize of the different symptoms of depression. You have to have 5 of the 9. And you have to have one of the first 2, those first 2 being a depressed mood and or anhedonia, which is when you don't enjoy things. And then we kind of move into the other symptoms, which are changes in appetite, meaning those can be higher or lower than normal, trouble sleeping or sleeping too much, loss of energy or increased fatigue. The psychomotor changes are kind of the hardest to screen for, which is either feeling very restless and, not being able to sit still or moving very slowly, and then feelings of guilt or worthlessness, and the last being suicidal thoughts. Now you can imagine that a lot of these overlap with normal symptoms of, having a newborn, like, difficulty sleeping or low energy. So, I think when you're picking up on things or asking about things, kind of contextualizing, are you not falling asleep because you are having negative thoughts, guilty thoughts, or anxious thoughts? So there, which I won't go into too much just because we've talked about it in previous lectures, but the Edinburgh scale is the one that we use the most for screening for postpartum depression, and it phrases things in a way to, take into account these factors of being pregnant or postpartum that would be expected versus something that would be a sign of depression. Um, so, other symptoms that you might see: difficulty concentrating, crying for no reason. There's a future lecture we're going to have about differentiating between baby blues and depression, so this one definitely with a grain of salt, and if you see it along with these other symptoms. And then here, specifically, things that you might see about the baby would be a lack of interest in the baby, feeling like you're not bonded to the baby, feeling very anxious around the baby, which would also lead us to think about screening more for anxiety symptoms. Being a bad mother, that's a common theme with postpartum depression. And again, the 2 weeks of symptoms is where we call it a depressive episode. So, depression and anxiety are often comorbid, meaning that they often happen together. So if you are seeing one, it's a good idea to think about and ask about symptoms and try to pick up on symptoms of anxiety also. The Edinburgh scale has some symptoms that it'll ask about anxiety, but not enough to really tease things out. So that will let us move into talking about perinatal anxiety. So the DSM has generalized anxiety disorder as our main diagnosis for clinical anxiety. There's obviously a bunch of other ones, but this is the most common one and the one that we screen for. Now, at its crux, patients will have excessive, uncontrollable worry that cause functional impairment. And if we see that, then, we can start teasing out the other symptoms. Interestingly, there is no DSM. When I say DSM, the Diagnostic and Statistical Manual, which we use for diagnoses, but there is no specifier for peripartum onset, which depression does have, which a lot of experts really feel like excludes a large, an important piece of the population. Anxiety disorders are much more likely to happen postpartum. Not only generalized anxiety, but others, and also. So, I think there is some discussion about really needing to be more inclusive in our future diagnostic manuals to include, again, anxiety disorders and with postpartum and peripartum onset. Anxiety is kind of dicey just because there's so many things to be anxious about when you're pregnant and postpartum. Problematic is the word that they use here. So symptoms like fatigue, irritability, muscle tension, concentration difficulties, insomnia, all of which are criteria for generalized anxiety disorder, can be mistaken as normal pregnancy and postpartum. So distinguishing these kind of normal worries from, clinical anxiety is important. And so that's why I've bolded these terms of where do we draw the line. So if it's disabling, the worries are disabling, recurrent, time-consuming, intrusive, and they acquire a quality of irrationality, then we start thinking, this is something that we might want to do something more about other than just, quell normal fears. If you think about the whole process, you start in the first trimester, you're worried about miscarrying, or if what you're taking or doing might affect your baby and cause malformations. And then as you progress, baby starts moving, and then you worry about why isn't baby moving? Then third trimester, you're gonna deliver. You're gonna sometimes be a first-time mom. how do you know what to expect? What kind of books can you read? Is it going to go okay? You're going to push a baby out of your body. What pregnancy or, delivery classes do I need to take? I mean, it's anxiety provoking for anyone. And so, I think using these concepts of it is impairing, and these other words to help us figure out, when do we need to get these patients help versus not. And sometimes it is gray because it is a spectrum. I would probably be more proactive. It doesn't mean we need to start a medication the second that they feel that anxiety is too high. It can be, let's talk and think about this. Let's bring this up with the OB. Let's see if we can start therapy. There's also a lot of common themes that I see with perinatal anxiety. We've talked about a couple of those, but fears of the baby being okay in utero and postpartum, fear that you're going to be okay through the whole process, how you're going to recover, fear that, your partner will have some kind of issue or illness, and then, fear of, which is an interesting one, but fear that either parent or both could, pass and leave the baby alone. Maybe that one's a little bit less common, but it does happen. Again, really bringing light to this functional impairment. And if we do let these things ride for an extended period of time, it can affect, we've talked about this in other lectures, but bonding and basically every aspect of a mother's life. So quickly we'll talk about, which I think I've also talked about in other lectures, but it is so important to differentiate. So apologies if it's repetitive, but postpartum psychosis, usually the result of some kind of mood disorder going to the extreme. So depression or bipolar. This is a psychiatric emergency and needs immediate attention. But what does it look like, right? So we can say that, but what does psychosis actually mean? So the types of psychosis that a person can have are delusions. What is a delusion? Thoughts that are not based in reality. Then there's the tree of different types of delusions that you can have, but things that people say that are, just clearly not true, and they have no insight about it. So take it, for example, the anxious patient who, is, say, super worried about the baby getting SIDS, and they're doing all the right things, but they're obsessed, or they cannot let that go. That is based in reality. They were, that is a real thing that happens and something that moms need to know about and should worry about, right? So that is not psychosis. But, thinking that baby is, some kind of religious figure and the new coming, that is not. So, I think, which most people, when you talk to somebody, you can differentiate that. Hallucinations, hearing or seeing things that aren't there. Auditory hallucinations are much more common than visual ones, but visual ones can happen. I would say that delusions are going to be the more common thing that you'll see with postpartum psychosis. And disorganized thinking, basically the person isn't making sense. Their thought pattern doesn't follow a line, right? They're switching topics quickly, and it's very incohesive. So, like I said, an emergency needs attention. We do not separate moms from babies lightly. So it is, we don't say it lightly that it's an emergency and that mom needs immediate attention. What we do know with postpartum psychosis is that it is not uncommon for baby to be involved in part of the delusion and for baby to be at a real risk. So we take this seriously, go to the ER, mom will likely be hospitalized and treated there. I think it's important, which, again, apologies for frequent watchers, something we've talked about before, but differentiating postpartum psychosis from OCD. So OCD, obsessive compulsive disorder, actually very, very common to be diagnosed for the first time postpartum. Why that is, I don't know, but one lecture I watched was that 50% of new adult diagnoses are done in the postpartum period. And I see it quite a lot. So what does that look like? OCD at its core, intrusive thoughts, usually very thematic, a lot of times very visual. And in the postpartum, frustratingly, a lot of times with baby getting hurt, either baby dying by accident, falling, dropping, or even hurting baby. Now, OCD is not a psychiatric emergency. Mom does not need to be separated from baby. And a big differentiating thing is that with OCD, these thoughts are what we call ego dystonic, meaning mom does not like these thoughts. They are very bothersome, and usually they don't even want to talk about it because it's so bothersome. So, I can imagine hearing that a mom is thinking that could be very jarring, but what we need to do is, pick up on mom recognizes that they're not real, recognizes that she doesn't want that, and get them, I would say, urgent attention just because it is so distressing to mom, but not because baby is at any risk. So I would say, I shouldn't speak in absolute, is in very minimal risk. So, and honestly, what I normally do, sometimes moms do feel comfortable communicating those thoughts, but sometimes they don't. They don't want to say what those intrusive thoughts are. I assume that a lot of times it is harming baby, that those thoughts, that's the theme. I don't make them say it if they don't want to. I can gather that it's intrusive, it's an image that they really don't like, and then we move from there, right? So I wouldn't push it if they don't feel comfortable with that. So if you see that, get them help. You don't need to get them to the hospital quickly. So when you see a red flag, again, not postpartum psychosis, we talked about that, but these symptoms, these flavors of, this is more than sadness, this is more than a little anxiety, this is affecting mom's life, and it's got all those other symptoms that we talked about. I think a good place to start, which this probably seems very obvious, but, setting that foundation, so working on building rapport with that patient, so a very non-judgmental, empathetic space. This is all taken for granted. We all know this. But sometimes rushing in with, you have this, diagnosing and, telling them what they need to do. I think just listening and empathizing is a good place, and you can pick up on where they're at in that, in their journey. Checking in with them frequently, providing that, support and offering, and which moves us to the next one. Once, you've normalized using psychiatric care for conditions and how biology and hormones play a role in, any depression, but also in any anxiety, but also in postpartum, peripartum depression and anxiety. Then you can say, move on to offering those resources. I think having those resources that you readily know available is really important. You don't want to, talk about it as a general idea, but then not be able to guide. Somebody who's depressed and anxious is going to struggle to, and who's pregnant or postpartum is going to struggle to have the time or energy to go find these resources, right? So it just adds another barrier. As us being in the field, having those ready to go and offering them, and offering to help them even engage with them and, set them up with those resources, would be the next step. I think it's really important to meet patients where they're at. If it's just introducing or talking about or, again, normalizing, I think that's great. We definitely don't want to scare patients off with interventions that they're not ready for. And sometimes, if patients are hesitant about medications, therapy is a great place to start. Therapists are excellent. It's a valid, wonderful form of treating both these conditions or all these conditions. But also, therapists can do a really good job of, again, gauging where a patient is at with medications and encouraging them if they feel like it's necessary, and also triaging if they feel like it's necessary. So those were all of my slides for today. I think next presentation will be talking more about medication use. I think it's good timing. There was recently a panel, I think, put on by the FDA with a lot of misinformation about treating perinatal conditions. So I am excited to include that in my presentation. I can tell you that in the world of perinatal psychiatry, people are pretty upset, and there's been statements from official websites to try to counter some of the information that was shared on those panels. But anyways, that is for another day. And I will see you guys at the Q&A and at the next lecture.